You know that sound, right? That sort of gentle, or maybe not so gentle, snore.
Hmm.
Or maybe it's the feeling you've been in bed for, I don't know, 8 hours, but you wake up feeling completely drained, just exhausted.
Yeah, like you haven't really slept at all. It's surprisingly common.
Exactly. Sleep's meant to be restorative, but sometimes it just isn't. And often, people don't even know why. So if you, or maybe someone you know, deals with that loud, chronic snoring or just that persistent, baffling tiredness, well, this deep dive is definitely for you.
We're focusing today on a very specific sleep disorder, obstructive sleep apnea, OSA.
Right, and we're working from a great resource here, a set of really detailed revision notes. Think of it like a high-yield guide, just
It,
on OSA.
it really is comprehensive, covers, well, everything from the basics of what it is right through to causes, risks, diagnosis, management, the lot.
So our mission today is to kind of unpack these notes together. We'll go through section by section, apply the key facts, the essential connections.
Basically give you a clear, solid understanding of OSA, fast. Get you the high-yield info without you having to wade through everything yourself.
Perfect. Okay, then let's dive in. Let's unpack this.
All right.
So starting at the top, definition. What exactly is obstructive sleep apnea, according to these notes?
Fundamentally, it's a sleep disorder where your upper airway, it gets blocked repeatedly while you're sleeping.
Right. Okay, that sounds significant. Does that mean your breathing actually stops?
It can, yes. That's what an apnoea is, a complete pause in breathing. But it's not just complete pauses. You can also have hypopnoeas.
Hypopnoeas.
Yeah, that's where the airflow is significantly reduced but not totally stopped. These notes define a complete apnea as lasting at least 10 seconds.
10 seconds.
Wow.
And a hypopnea is defined as ventilation being cut by at least 50%. Imagine holding your breath for 10 seconds over and over all night.
That really puts it in perspective. 10 seconds feels like a long time when you think about breathing. Exactly, and it's these repetitive events, the apnoeas and hypopneas that are the core problem. They lead to two main consequences: drops in your blood oxygen levels and really fragmented, poor quality sleep.
Okay, and the notes mention research focusing on that sleep fragmentation aspect.
Right, and also on objectively measuring the airway obstruction itself. It's not just that breathing is disrupted, but understanding how disrupted and the knock-on effects on sleep stages and oxygen.
Makes sense. So why does this happen? What causes the airway to block like that? The etiology.
Well, the primary issue is that collapse or significant narrowing of the upper airway during sleep.
And what makes it collapse? What are the contributing factors listed in our source?
It's usually a combination of things. So as you fall asleep, your throat muscles naturally relax. That's normal.
Okay.
But in someone prone to OSA, that relaxation goes a bit too far. The airway walls become floppy or narrow too much.
And obesity is mentioned as a big one here.
Oh, absolutely crucial. Excess weight, particularly fat deposits around the neck area, can physically squash the airway, making it smaller and much more likely to collapse when the muscles relax.
So physical pressure from the outside.
Exactly. Then there are anatomical issues, things like having large tonsils or adenoids, especially common in children with OSA, or having a smaller jaw or a jaw that's set back a bit, craniofacial differences.
Things you're just built with, essentially.
Right. And getting older is another factor. Muscle tone generally decreases with age, including in the throat.
That makes intuitive sense.
Then you've got hormonal changes, certain medical conditions, like chronic nasal congestion or hypothyroidism, which can actually cause the tongue to enlarge, macroglossia.
An enlarged tongue. Wow, okay.
Yeah, physically blocking the space. And finally, lifestyle choices play a role too. Smoking, drinking alcohol, especially in your bedtime.
So it's a real mix. Anatomy, weight, age, muscles, habits. Quite complex.
Definitely. Which leads us nicely into the risk factors. Who's most likely to actually develop OSA based on this guide?
Let's break those down.
Okay, so number one, as we said, is obesity. The notes specify a BMI over 28 kilonewton-meters as a key threshold, directly linked to that airway narrowing,
Right.
advanced age because of that muscle tone decrease. And being male men are significantly more likely to have OSA than women, although it definitely occurs in women too, especially postmenopause.
So statistically, older, heavier men are often the highest risk group.
Generally, yes, that's what the data suggests. Then there are those specific anatomical features we touched on. Having a large neck circumference, just structurally having a narrow airway, or other craniofacial abnormalities.
And you mentioned physical blockages too, the mechanical obstructions.
Yeah, things like persistent sinus infections or allergies causing swelling. Enlarged tonsils or adenoids, as I said, are a big factor in kids. Less commonly, things like nasal tumors, hypothyroidism again with the enlarged tongue, and some neuromuscular diseases that affect muscle control.
The notes also point to family history, don't they? Snoring or known OSA in the family.
They do, yeah. Suggests there could be a genetic component or perhaps shared environmental factors or body types running in families. And of course, smoking is listed again as a risk factor itself.
What's really striking, though, is the long list of associated medical conditions. OSA rarely seems to exist in a vacuum.
That list is pretty eye-opening, isn't it? Things like obesity, hypoventilation syndrome, pregnancy, end-stage kidney disease, congestive heart failure, chronic lung disease, type 2 diabetes, stroke.
Acromegaly, hypothyroidism, PCOS, even something called floppy eyelid syndrome.
Yeah, it's extensive. It really highlights how connected sleep-disordered breathing is to overall systemic health. These conditions can worsen OSA, and OSA can contribute to worsening them. It's often a two-way street. Understanding these links is really vital.
Okay, let's drill down into the mechanics, the pathophysiology. What actually happens step by step during sleep when someone has one of these events?
All right, so imagine you're drifting off to sleep. Your throat muscles relax, as they should. But in someone with OSA, because of those risk factors, maybe excess weight, maybe anatomy, that relaxation allows the upper airway tissues to collapse inwards or narrow significantly.
Blocking the passage for air.
Exactly. Airflow becomes limited or stops completely. Your body immediately senses the oxygen level in your blood starts to drop, and carbon dioxide builds up.
That sounds like an alarm signal.
It is. It triggers a stress response. Your brain briefly jolts awake. It's called a microarousal. Often it's so brief, you won't consciously remember waking up at all.
But it's enough to fix the breathing.
Yes, just enough to increase muscle tone slightly, tense things up, and pull the airway open again. So you take a few breaths, maybe gasp or snort.
Okay.
But then as you fall back into deeper sleep, the muscles relax again, the airway collapses again, and the whole cycle starts over.
So it's this constant loop. Collapse, oxygen drops, brain wakes slightly, airway opens, fall asleep, collapse again.
Precisely. Happening potentially dozens or even hundreds of times every single night.
Hundreds. Wow.
And it's these relentless microarousals that absolutely wreck your sleep quality. They fragment your sleep, preventing you from spending enough time in the deep restorative stages of sleep, like deep NREM and REM sleep.
So even if you're in bed for 8 hours, you're not getting 8 hours of quality sleep.
Not even close, potentially. And that's what leads to the classic symptoms like severe daytime sleepiness, difficulty concentrating, irritability, even if the person has no memory of waking up during the night.
That makes so much sense now, seeing the cycle. But the notes also caution not everything that makes you tired or snore is OSA, right? There are differential diagnoses.
That's a really important point. You can't just assume. We need to consider other possibilities that might mimic OSA symptoms or even coexist alongside it.
Like what?
Well, other sleep breathing issues for starters, like central sleep apnoea, that's different because the brain isn't sending the signal to breathe. It's not a physical blockage. Or complex sleep apnea, which is a mix. Or even just primary snoring, where there's noise but not the significant breathing pauses or oxygen drops.
So snoring doesn't automatically equal OSA.
Correct. Then there are issues just with poor sleep habits, maybe chronic sleep deprivation because of lifestyle, or the effects of shift work messing with your body clock, or just generally fragmented sleep from other causes.
What about mental health or neurological things?
Yes, depression can cause fatigue. Narcolepsy causes severe daytime sleepiness. Untreated hypothyroidism, restless leg syndrome, these can all overlap symptomatically.
And medications or substances?
Definitely. Sedatives, some stimulants, certain heart or mood medications like beta blockers or SSRIs, and obviously excessive alcohol, they can all interfere with sleep architecture or breathing control.
And the notes remind us again about those associated diseases, hypertension, diabetes, heart disease.
Right, because sometimes the symptoms might primarily be from one of those conditions, or they might be making the OSA worse, or vice versa. It's all interconnected.
Okay, shifting focus a bit. Let's look at the epidemiology. How common is OSA? The notes give UK figures.
Yeah, the prevalence is quite striking. The source suggests around 4% of middle-aged adults in the UK have OSA.
4%. That's quite a few people.
It is. And it jumps significantly in older age groups, up to 10% in people over 65.
And it confirms the gender difference, too. More common in men.
Yes, more prevalent in men. And critically, the notes state the incidence seems to be increasing.
Increasing? Why?
The source directly links this trend to rising rates of obesity in the population.
Ah, okay. Back to obesity being a key driver.
Exactly. And unsurprising, it's also more common in people who already have obesity, hypertension, or diabetes. It reinforces those strong links between these conditions.
So it's definitely a growing public health issue, often tangled up with other major chronic diseases.
Hmm.
Which brings us to how it actually shows up for the person experiencing it, the clinical presentation. What are the key signs and symptoms mentioned?
The guide gives a really clear list. Often the first thing noticed, usually by a partner, is the loud, chronic snoring.
Can't miss that sometimes.
Quite, and often that partner will also witness the actual breathing pauses, which can be pretty alarming to see.
I bet. And for the person themselves.
The biggest impact symptomatically is usually that excessive daytime sleepiness. And we're not just talking about feeling a bit tired, it can be overwhelming fatigue, leading to unintentionally falling asleep during the day, difficulty concentrating, staying awake while driving.
That sounds really debilitating and dangerous.
It can be. Other common things people report are waking up with headaches in the morning, or really dry mouth or sore throat.
From breathing through the mouth all night, probably.
Likely, yeah. Also, difficulty concentrating during the day, feeling irritable, having restless sleep, feeling like you're tossing and turning a lot, and sometimes needing to get up to pee frequently at night, nocturia, or experiencing sexual dysfunction.
Any other sounds people might make?
Patients might describe waking up suddenly, maybe snorting or choking, gasping for breath. It all points back to that disrupted sleep and the body struggling to get air.
And the notes mention how diagnosis works.
Mm.
Symptoms plus testing.
Yes, clinical symptoms are crucial, but the diagnosis needs to be confirmed with objective testing. The gold standard test is usually nocturnal polysomnography, the overnight sleep study, or PSG.
PSG. And the key measure from that is the AHI.
Exactly, the apnoea-hypopnea index. Our notes highlight the diagnostic thresholds. An AHI of 15 or more events per hour confirms OSA even without symptoms. But if someone does have typical symptoms like excessive sleepiness, then an AHI of just 5 or more events per hour is enough for diagnosis.
5 times an hour, your breathing is significantly disrupted. Yeah, I can see how that adds up. What about screening, everyone?
Well, the source mentions that major bodies like the AASM don't generally recommend mass screening of asymptomatic people in the community using just questionnaires.
Why not?
Mainly because the questionnaires aren't specific enough. They can flag lots of people who don't actually have OSA, leading to unnecessary worry and further testing. False positives.
So they can be useful sometimes. Pre-surgery, maybe?
Yes, exactly. The Stop-A-Bang questionnaire is specifically mentioned as a useful tool before surgery if there's a clinical suspicion of OSA. A score of 3 or more on that suggests a higher risk and probably warrants a proper sleep study.
Okay, so if the symptoms and maybe a screening tool point towards OSA, how do you investigate properly? Nail down the diagnosis and severity.
Right, investigations. As we said, the definitive test is that overnight sleep study, the nocturnal polysomnography, or PSG.
What exactly does PSG measure? It sounds complex.
It is quite comprehensive. It records multiple things simultaneously while you sleep. Brain waves, the EEG, to see your sleep stages, eye movements, EOG, muscle activity, EMG, often on the chin and legs, airflow through your nose and mouth, your breathing effort, chest and abdominal movements, blood oxygen saturation levels using a pulse oximeter, heart rate, even limb movements.
Wow, okay, so it paints a really detailed picture of sleep and breathing.
Absolutely. It allows specialists to precisely count the apnoeas and hypopnoeas, see how long they last, how much oxygen drops, and critically, how they disrupt the normal sleep cycle.
And these studies can be done at home, too, now.
Yes, the notes mention both traditional in-lab PSG and home sleep apnoea testing, or HSAT. HSAT devices are simpler but still capture key data like airflow, effort, and oxygen levels.
And the diagnostic criteria are the same. 5 events per hour with symptoms.
That's the key threshold mentioned again, yes. And the notes also add, importantly, that if an initial study is negative, but the symptoms are really strongly suggestive of OSA, it might be worth repeating the test. Sometimes one night isn't fully representative.
Good point. Does PSG help find other things, too?
It can, yes. It can help identify or rule out other sleep disorders that might be causing symptoms like narcolepsy, periodic limb movement disorder, restless legs syndrome, or even nocturnal seizures.
And what about checking for related conditions?
The source suggests checking thyroid-stimulating hormone, TSH, if hypothyroidism is suspected, given the link, and also routinely checking blood pressure and doing a fasting blood sugar, or HbA1c, to screen for diabetes, given the strong associations.
Let's just revisit that AHI severity scale one more time, as it seems central.
Definitely. So the AHI apnoe hypopnea index is the average number of breathing events per hour of sleep. Based on these notes, mild OSA is an AHI between 5 and 14.9. Moderate OSA is 15 to 29.9, and severe OSA is an AHI of 30 or more events per hour.
30 times an hour or more. That's every couple of minutes.
Yeah, in severe cases, it can be relentless. The higher the AHI, generally the greater the sleep disruption and oxygen desaturation.
What if getting a full PSG or even HSAT is difficult? Are there simpler options?
The notes do mention simpler approaches like overnight oximetry alone, just measuring oxygen levels, or other limited home monitoring systems. These might be used for initial assessment or where access to full studies is limited. Some home systems specifically measure snoring, airflow, and oxygen. They also mention using binders or effort sensors to help tell if a pause is obstructive, chest moving, no air, or central, no effort to breathe.
Can doctors look directly at the airway?
Yes, nasolaryngoscopy using a small camera through the nose is mentioned as a way to visually inspect the upper airway anatomy, check for large tonsils, tongue base issues, etc. Other blood tests like full thyroid function tests, TFTs, or maybe arterial blood gases could be used in specific situations. For example, if someone has symptoms suggesting related heart or lung complications like cor pulmonale.
And the UK's NICE guidelines have specific recommendations on the investigation pathway.
They do. NICE generally advises starting with home-based respiratory polygraphy if possible. If access to that is limited, home oximetry can be used. But crucially, if these simpler tests are negative but symptoms are strongly suggestive, NICE recommends proceeding to full PSG or polygraphy to get a definitive diagnosis and assess severity properly. The sleep study, in some form, is key.
Okay, so let's say the diagnosis is confirmed, severity is known. What happens next? How is OSA managed?
Right, management. The guide stresses it needs to be tailored to the individual severity, symptoms, preferences, other health issues all play a role. But the core approaches are mainly non-prescribing.
Starting with those conservative measures.
Exactly. Education is first, making sure the person understands OSA and, importantly, the risks of daytime sleepiness, especially around driving or operating machinery. Safety is paramount.
And weight loss.
Hugely important. It can significantly improve AHI and symptoms for many people. Though the notes do caution it's rarely a complete cure on its own, it's a critical part of the plan if overweight or obesity is a factor.
What about sleep position?
Avoiding sleeping flat on the back, the supine position is often advised, as gravity can make the airway collapse worse. Positional therapy, using devices or techniques to encourage side sleeping, can be very effective, especially for people whose OSA is much worse when they're on their back.
And avoiding certain things.
Yes, cutting down on or avoiding alcohol, especially in the evenings, and avoiding sedatives or sleeping pills is key, as these relax the throat muscles further. Quitting smoking is also beneficial. And treating any nasal problems, like allergies causing congestion, can help improve airflow through the nose.
Okay, those are the lifestyle and basic measures. What about specific treatments?
The main most effective treatment highlighted is positive airway pressure therapy, or PP.
PP.
Yeah, usually continuous positive airway pressure, CPAP. The notes call this the primary treatment, the gold standard.
How does CPAP work?
It involves wearing a mask over the nose or nose and mouth while sleeping. The mask is connected to a small machine that delivers pressurized air. It's not forcing you to breathe, but it creates a gentle, positive pressure that acts like an air splint to physically keep the upper airway open, preventing it from collapsing.
So it stops the apnoeas from happening.
Exactly. And the recommendation is to use it consistently, ideally for at least 4 hours per night, every night, to get the full benefit.
Is there another type? BiPAP?
Yes, bi-level positive airway pressure, BiPAP. This delivers two different pressure levels, a higher one when you inhale, a lower one when you exhale. The notes say it might be used for more severe OSA if someone finds CPAP difficult to tolerate, or if they have coexisting problems like hypoventilation.
What if someone really can't tolerate wearing a mask? Are there alternatives?
Yes, dental appliances are another option. These are often called mandibular advancement splints or devices, as MAN'Ed.
How they work?
They're custom-fitted devices, a bit like a mouth guard, worn during sleep. They work by gently holding the lower jaw and tongue slightly forward, which helps to open up the space at the back of the throat.
Who are they suitable for?
The notes position them as an alternative to CPAP, especially for people with mild to moderate OSA. NICE in the UK does recommend them for certain patients who meet criteria or can't use CPAP. They're generally safe, though can sometimes cause jaw discomfort or bite changes initially.
And if PAPI and dental devices don't work, or aren't suitable.
Yeah.
Surgery.
Surgery is usually considered further down the line if those less invasive options fail, or if there's a very specific correctable anatomical blockage. Examples mentioned include procedures like uvulopalatopharyngoplasty, UPPP, which removes tissue from the soft palate, and uvula or tonsillectomy, particularly if very large tonsils are clearly the primary cause. NICE also has specific guidance on when surgery might be appropriate.
What about medications? Is there a pill for OSA?
According to these notes, the role of medication for treating the OSA itself, the breathing events, is very limited. More research is needed. Modafinil is mentioned, but only as a possible adjunctive therapy.
Adjunctive, meaning?
Used in addition to effective CPAP treatment, specifically for any residual excessive daytime sleepiness that persists despite good CPAP use. But even then, the notes say it's controversial and has potential side effects. There's no strong recommendation for drugs to treat the apnoeas directly.
And some drugs are specifically not recommended.
Right. The notes point out that NICE has specifically not recommended newer wakefulness-promoting agents like solriamfetol and pitolisant hydrochloride for OSA in the UK.
But medication is used for related issues, like rhinitis.
Oh, yes, absolutely. If nasal allergies or inflammation are contributing to blockage, treating that is important. The notes suggest starting with things like topical nasal steroid sprays or antihistamines. If that doesn't work, or if there's a structural issue, then referral to an ear, nose, and throat ENT specialist is recommended.
So, summing up management.
Okay.
It's tailored, lifestyle is key, CPAP is the gold standard, dental devices are an option, surgery is selective, and meds for the apnoeas themselves have a very limited role.
That's a perfect summary of the key takeaways from this section of the guide.
Which leads us to prognosis. If someone gets diagnosed and managed, what's the outlook?
Generally, the prognosis is favorable, but, and this is the crucial part from the notes, with appropriate management.
So treatment really works.
Yes, effective treatment, especially CPAP, can dramatically control the symptoms, improve sleep quality, boost daytime alertness and concentration, improve quality of life.
What about the long-term health risks we talked about? Does treatment help with those?
That's where long-term adherence comes in. Sticking with the treatment, like using CPAP consistently and maintaining those lifestyle changes like weight management, is absolutely vital for seeing sustained benefits, including reducing those long-term risks.
And the flip side, if it's not managed?
Well, the notes are very clear. Failure to manage OSA significantly increases the risk of serious cardiovascular problems, hypertension, arrhythmias like atrial fibrillation, heart failure, stroke. It also contributes to cognitive issues, memory problems, and that increased risk of accidents due to sleepiness.
Let's just hammer home those complications of untreated OSA one last time. They sound serious.
They really are. Untreated OSA isn't just about feeling tired, it's a major health hazard. Top of the list in the notes, cardiovascular diseases, increased risk of high blood pressure, heart failure, coronary artery disease, stroke.
And the impact on the brain and daily life.
Cognitive impairment, trouble concentrating, memory issues, increased irritability, links to depression. And that excessive daytime sleepiness is a huge factor, leading to impaired work performance and a significantly higher risk of accidents, particularly driving accidents. The notes explicitly state driving ability can be affected, potentially requiring restrictions until it's treated effectively.
Are there metabolic links too?
Yes, untreated OSA is associated with an increased risk of developing insulin resistance and type 2 diabetes. It's often part of that cluster of conditions linked with obesity and metabolic syndrome.
But there's good news if it is treated.
Definitely. That's the positive message highlighted in the source. Successful management, particularly with CPAP, can reduce cardiovascular complications. It can help lower blood pressure. And interestingly, it's even been shown to decrease all-cause mortality in patients who have both hypertension and OSA.
So treating the sleep disorder is actually a critical part of managing their overall cardiovascular and metabolic health.
Precisely. It's not just about sleep. It's about reducing the risk of these other major, potentially life-threatening conditions.
Wow. Okay. So there we have it. We've really taken a deep dive into these detailed revision notes on obstructive sleep apnea. Pulled out the essentials.
Yeah, from the basic definition, those apnoeas, hypopnoeas, through the causes, who's at risk, what happens physiologically.
Right, how it presents, how it's investigated using things like PSG and AHI, and then the whole range of management strategies, really emphasizing lifestyle and CPAP as the cornerstone, plus the prognosis, and those serious complications if it's left untreated.
You should now have a really solid, high-yield overview straight from the key information in this guide.
Exactly. That's the power of doing this deep dive, getting that essential knowledge efficiently. And, when you step back and think about how common OSA is, especially with obesity on the rise, and you see these clear links to huge health problems like heart disease, stroke, diabetes, it really makes you think, doesn't it?
It does. What are the bigger implications for public health? For screening? For how we manage chronic diseases?
Yeah, should we be thinking more proactively about sleep health as part of routine care? It really frames sleep not just as, downtime, but as a critical pillar of overall health, deeply connected to some of our biggest health challenges. It certainly makes you think differently about that snore you might hear tonight.